We're now going to look at some cardiovascular conditions. And as we start to look at those cardiovascular defects, we really need to review some normal physiology. If we take a look at the fetal circulation, we note that, first off, if we talk about arteries, umbilical arteries and veins, there are 2 umbilical arteries and 1 vein. And that umbilical vein takes blood from the placenta to the baby and joins the vena cava right at the ductus venosus. It's right behind the liver. You can see that transparent liver in the picture. Then this oxygenated blood goes back to the heart. And I need to ask you, do the lungs serve any purpose in the fetus? And the answer is no. So there is a chance to bypass the lungs. This foramen ovale here is a hole between the atria, so there's a chance to bypass the lungs. The blood goes from the right atria directly over into the left atria. Now there's a little bit of blood, obviously, that will end up going down into the right ventricle and out the pulmonary artery. And there's one more chance now to bypass the lungs, and that is your ductus arteriosus. And this goes from artery to artery, from the aorta to the pulmonary, or from the pulmonary artery to the aorta. And this is the second chance to bypass the lungs. So we need to remember the foramen ovale is the first chance to bypass the lungs, and then the ductus arteriosus is the second chance to bypass the lungs. These are the sources of some of our heart defects, in fact. When we start to talk about heart defects, we can classify these in a couple of different ways. We can classify these as acyanotic, meaning there is no unoxygenated blood in the systemic circulation, or cyanotic, meaning there is oxygenated blood, unoxygenated blood in the systemic circulation. We can also talk about what happens to the blood flow. So the first one of the defects I want us to talk about is a patent ductus arteriosus. The ductus arteriosus that we just mentioned when we talked about circulation. This is a connection between the pulmonary artery and the aorta that in the fetus allows blood to bypass the lungs. Well, once the baby is born and takes first breath, essentially, the lungs now become inflated with air and the pressure gradients change. This ductus arteriosus is supposed to functionally close almost immediately. Occasionally it does not. If it does not, then the blood, because of now the changes in the pressure, the blood would go from the aorta backwards through that ductus arteriosus into and go back through the lungs to the pulmonary artery to the lungs the second time. So this defect is classed as an acyanotic defect and also one that causes an increase in pulmonary blood flow. Now most kids that have this disease may have some growth impairment. They may not eat as well. With most heart defects, they don't grow as well, they may not eat as well. They usually have some problems with exercise tolerance. With the patent ductus arteriosus, there's a murmur. A murmur, remember, is the sound of blood going someplace it's not supposed to be. And this is often described as a machinery murmur or kind of a rat-a-tat-tat sounding type of murmur. Another characteristic is a wide pulse pressure. Remember, that's the difference between systolic and diastolic pressures. This is going to usually be treated by surgery, frequently sometime before the child goes to school. And most children will do quite well with this problem. Another heart defect that we want to look at is the atrial septal defect. We talked about that foramen ovale, a normal hole between the atria that's supposed to functionally close within the first few breaths that the infant takes after birth. If this stays open, then blood is now moving from the left atria to the right, because after birth the pressure is greater on the left side of the heart than the right. So we refer to this as a left to right shunt. It's also classified as an acyanotic defect, or one that increases pulmonic blood flow because the blood goes through the lungs a second time. It will usually be treated by surgery, either direct closure or prosthesis is necessary, again, usually sometime before the child starts school. Another one of these acyanotic defects is a ventricular septal defect. And this one, there is a hole in the ventricular wall. And again, the blood will go from the left ventricle through that hole into the right ventricle and back through the lungs a second time. So this is also a defect that results in an increase in pulmonic blood flow. Again, the children have a murmur, they don't grow very well, they don't eat very well. Surgery is usually done sometime in the preschool years. Another heart defect is coarctation of the aorta. And you can see in this picture that that aorta is extremely narrowed. One of the characteristic assessment findings of this is that the blood pressure is higher in the upper extremities and lower in the lower extremities. And again, the pulses are weaker in the lower extremities because not as much blood is flowing to those extremities. Oftentimes, the child will develop the left ventricular hypertrophy as well. Surgery is again the treatment for this. We're now going to look at cyanotic defects, the biggest of these being tetralogy of Fallot. Now tetra means 4, so there are 4 defects. The first of these defects is a pulmonic stenosis. So this pulmonic valve is narrowed and it makes it hard for the blood to get through the pulmonary artery into the lungs. So it's a reduced blood supply to the lungs. This in turn causes this right ventricular hypertrophy. So the right ventricle will enlarge. So we'll get right ventricular hypertrophy. Now notice that those 2 defects go together, the pulmonic stenosis and the right ventricular hypertrophy. Now there's also a ventricular septal defect. So there's a hole in the ventricular septum between the right and left ventricles. This allows blood to go between the 2 ventricles. And to make matters worse, the aorta is on top of this septal defect. So every time the ventricles beat, blood from both the left and the right ventricles goes out through the aorta. Now, when the right ventricular blood goes out through the aorta, this blood has never been to the lungs. So you can see the blue dots in the aorta representing unoxygenated blood coming from the right ventricle through that ventricular septal defect in the overriding aorta. This means that the child has unoxygenated blood in the systemic circulation. These are the children that have frequently been called blue babies. These children turn blue, and we often see cyanosis with physical exertion. We see these are children that do the squatting. And the reason they squat is that this will increase the intra-abdominal pressure and then increase the amount of blood that's going out through the pulmonary artery to the lungs. They get clubbing of fingers and toes. It's kind of a squat, fat area around the ends of the fingers and toes. This is the body's attempt to increase the vascular bed there, to increase the blood supply to that section. They get paroxysmal dyspnea attacks, or sometimes people call them tet spells, where they get suddenly extremely short of breath, and they usually then sit down and squat. They're going to have a murmur as well because of those defects. Usually children with tetralogy don't grow very well. The treatment is going to be surgery, often multiple surgeries. So they may have a surgery that creates a defect that brings more blood to go to the lungs, and then they will later on do some more surgery. So they may have had 2 or 3 open heart surgeries. Usually we like to do this surgery if we can before they get starting in school. Now, to summarize a little bit about some of those defects causing increased pulmonary blood flow, the patent ductus arteriosus, atrial septal defect, ventricular septal defect. Now, mixed blood flow is what we see in tetralogy of Fallot. So we have a mixed blood flow. A question for us. The nurse is doing preoperative teaching for a 6-year-old child who is to have open heart surgery. What is the best teaching technique? Encourage him to practice procedures that will be performed postoperatively. 2, give him a book about open heart surgery to read. 3, explain the surgery to the child's mother and have her explain it to him. Or 4, arrange for the child to discuss open heart surgery and postoperative care with a group of children who have had open heart surgery. Now, this child is 6 years old. The answer is number 1. A 6-year-old child is a very concrete learner, so they need to practice and do what needs to be done. At 6, they can read, but not well enough to read a book about surgery, and they don't have enough abstract thinking to know that that's going to apply to them. And that answer that talked about getting them together in a group, answer number 4. This might be more appropriate at 16, but a 6-year-old doesn't have the verbal and cognitive skills to do that. So as we said, the answer was number 1. Another question for us. A 6-year-old who has tetralogy of Fallot was admitted for surgery. He suddenly squats with his arms thrown over his knees and his knees drawn up to his chest. What is the best immediate nursing action? Observe the child and assist as needed. 2, place the child in a lying position. 3, call for help and return the child to his room. Or 4, assist the child to a standing position. And the best answer is number 1. Assuming the squat position is what is best for him. That's going to increase the pulmonic blood flow and perhaps help to reduce his dyspnea. The nurse is admitting a 10-year-old girl who has rheumatic fever. What is the child most likely to have in her history? A tick bite 3 weeks ago, pharyngitis 2 weeks ago, prolonged contact with an infected pet, or parents who have the disease? And the answer is number 2, pharyngitis 2 weeks ago, because rheumatic fever frequently follows beta hemolytic strep infections. So the child is likely to have had a history of strep throat, which might be recorded as pharyngitis or sore throat within the last 3 weeks. In addition to that history of strep throat, oftentimes we'll see carditis, that's inflammation of the heart, Aschoff bodies, polymigratory arthritis. Usually it's large joints, and the child may say, my right knee hurts. And then a little later say, my left knee hurts. And mother says, make up your mind which knee hurts. And the child says, I can't help it. It moves around. That's what we mean by polymigratory. Poly, more than one, migratory moves. Chorea is involuntary kinds of movements. So they might be having shaking and involuntary movements. Those are temporary. They're not going to be permanent. Nodules, subcutaneous nodules in various parts of the body. A rash on the abdomen, that erythema nodosum. In addition, the blood work is probably going to show sed rate, ESR, and C-reactive protein elevated, indicating inflammation. And the ASO, anti-streptolysin titer, suggests that we have a strep infection. Now, the treatment for someone with rheumatic fever usually involves penicillin during the acute phase, and traditionally for many years we did prophylactic penicillin until the child was 20 years old, or for 5 years, whichever was longer. And before surgery they would be getting penicillin. Some doctors are still doing this. Not everyone is still doing this prophylactic penicillin treatment. In addition, the child will probably be on steroids, which are anti-inflammatory. They might be getting antipyretics or analgesics because of the pain. They're likely to be on bed rest. Oftentimes we keep them on bed rest until the sed rates and C-reactive proteins are back to normal, indicating the inflammatory process is over with.